All right, Ninja Nerds, in this video we're going to talk about the facial nerve, or cranial nerve 7. It's a very important nerve, so we're going to spend a decent amount of time on it. So what are we going to talk about in this video? We're going to talk about the origin of the nerve. Okay, where does this nerve actually originate? Where in the brainstem? What are some of the nuclei that's nearby? Okay. The next thing we're going to talk about is the course of the nerve. This is where we're going to spend a decent amount of time. Okay, so the course of the nerve is we're going to talk about all the branches, what holes it's running through, where is it going. Then we're going to talk about the structures that it's supplying. What are the functions of those structures? And then the last thing we're going to talk about is certain clinical correlations that can occur due to certain types of lesions, whether it be due to lesions with inside of the brainstem or it be due to peripheral nerve lesions and how that can affect these patients. All right, so let's go ahead and get started. So the first thing we're going to look at here is we're going to look at the facial nerve, right? So if you guys remember when we talked about the abducens nerve, you know the abducens nerve was located within the, right here in the pons also. And if you remember, here was your sixth cranial nerve, abducens nerve. And if you also remember, there was going to be, what's this structure right here? This is going to be the fourth ventricle. If you remember correctly, the facial nerve is extremely interesting because it has many, many different nuclei that are making up this entire nerve. We're going to start first with the motor fibers, Now, this nucleus, the facial nerve nucleus, the motor nucleus here, is going to be located within the pons. What happens is its axons are going to move around cranial nerve 6, the nuclei of cranial nerve 6. When it moves around it, if you guys remember, we said it produced a little depression inside of the actual fourth ventricle called the facial colliculus. And then what happens? It actually will move forward anteriorly and then move downward and move right around that pons medulla junction lateral to the abducens nerve exit. So it'll come out here, all right? So that was this one. That was the motor nucleus. Now the motor nucleus is very, very special. Why? Because these fibers that are going to be these motor fibers are very, very specific. These motor fibers, I'm going to write it up here, kind of put it like this, that this red is going to identify that these fibers here are going to be what's called SVE fibers. Now I talked about this a little bit, but I want to be more specifically because I didn't really spend a decent amount of time on this. We'll talk about pharyngeal arches more in embryology, but SVE talks about meaning specifically special, visceral, efferents, meaning it's going away from the central nervous system. These fibers of the facial nerve are going to be going to a specific part of the pharyngeal arches. So you have pharyngeal arch 1, 2, 3, 4, and 6. 1, if you guys remember, was supplied by the trigeminal nerve. 2 was supplied specifically by the facial nerve, right? 3 is going to be supplied by the glossopharyngeal nerve, and then 4 and 6 are going to be supplied by the vagus. So it's during the embryonic development that these actual pharyngeal arches develop. And again, which one is the actual facial nerve supplying? It's supplying specifically the second pharyngeal arch. And this is going to go to specifically the muscles of facial expression and some muscles called like the digastric posterior belly and the stylohyoid. We'll talk about that. Okay, so special visceral efferent fibers. And they're going to come out at the pons medulla junction right there, more lateral to the sixth nerve. And they're going to go through a nice big hole here in the back of the actual, there's what's called the petrous part of the temporal bone. Right here in the petrous part of the temporal bone, there's a nice little hole here. Let's make this a pretty big hole because there's going to be a lot of fibers running through here. This nice little hole here is called the internal acoustic or auditory meatus. So it's called the internal or internal acoustic, so we can call this the internal acoustic meatus, okay? Or internal auditory meatus. These motor fibers move through the internal acoustic meatus and they'll move out to a specific part, which we're going to talk about. It'll go into what's called the tympanic cavity, the middle ear cavity. Okay, so that's that one. Now let's discuss this green nucleus. And this green nucleus is very, very special. This is probably going to be one of the more complicated ones of the facial nerve. This is actually going to be the SVE fibers. Now, first off, what is this nucleus called? We could say, oh, it's another facial nerve nucleus. No, that's the facial nerve nucleus, which is carrying the branchiomotor fibers, the motor fibers to the second pharyngeal arch, right? Muscles of facial expression, digastric posterior belly, and stylohyoid. This nucleus is very different. This nucleus is actually called the, I'm going to write it up here, this is actually called the superior salivatory nucleus. And this carries what's called lacrimation fibers and salivatory fibers, and we'll talk about that. What does GVE stand for? GVE specifically stands for general visceral efferents. Now, what is this going to go to? We'll talk about it in a second, but it's going to specifically be going to the lacrimal glands and the nasal glands, and then also a little bit to the palatine glands. But main one is going to be lacrimal and nasal glands, and you guys will see when we go through the greater petrosal nerve and its different parts, right? All right, so that's the superior salivatory nucleus, right? And its fibers are going to go out with the facial nerve here, right? The actual, they call this the facial nerve proper, the red line here, right? Where the actual branchiomotor fibers are moving with. So this is where the actual GVE fibers are going to move. It's also going to move with the facial nerve proper, or these red fibers here, these SVE fibers. All right, cool, so we got that taken care of. What's this big blue sucker right here? That big blue sucker right there is called the spinal nucleus of the trigeminal nerve. So it's called the spinal nucleus of cranial nerve 5. And what was important about this one, if you guys remember when we talked about the trigeminal nerve, it picks up touch, pain, temperature, proprioception, and pressure, right? So this is going to be very, very important for the specific types of fibers called the GSA fibers. And we'll talk about these. The GSA fibers stand for general somatic afferents. And these are specifically for touch, pain, temperature, and a little bit of proprioception and even pressure. Okay? So that's this one. We'll talk about how those feed in. All right, now we go to this brown one here. And this brown nucleus right here is actually going to be called a very, very specific one. This is actually called I'm going to put nucleus of tractus solitarius. I've talked about this many, many times, right? And this nucleus of tractus solitarius is actually going to be receiving two types of fibers. One is SVA fibers. You know, we talked a little bit about SVA fibers during the gustation video. There's two different types of fibers, SVA fibers and SSA fibers. So let me just really quickly here, let's say here that I put SSA and SVA fibers. SSA stands for special sensory afferents. There are two types of this one. One is like the optic nerve. So the optic nerve carries special sensory afferents, right? And then also the vestibulocochlear nerve. The vestibulocochlear nerve is also going to carry special sensory afferents. Whereas taste or gustation, so they call it gustation, and olfaction, smell. These are special visceral afferents. So the facial nerve also has special visceral afferents for taste of the anterior anterior 2/3 of the tongue. So this is consisting of special visceral afferents. And again, this is going to be for taste of anterior 2/3 of tongue. Holy bejeebies, right? There's a lot of stuff there. And the next one is not so important. It's not so important, we're only going to mention it, but it's not super, super significant. I'm going to do this one in a different color. Actually, I'll write it like here, but I'll show the fibers in different colors. Okay? The other one is GVA fibers. And this is just called general visceral afferents. And these are mainly going to be for visceral sensations of the soft palate. Okay, so they're going to primarily be supplying the soft palate. Okay, so maybe different types of touch, pain, temperature of the soft palate. Not super, super important, but we're going to just show it quickly there. And then for the last one was that this blue structure, not we're going to really write up anything up there, but this is actually going to be for the dorsal nucleus of vagus. And they do believe that this GVA can either send it to two parts, the nucleus of tractus solitarius, or it can send it to another structure over here, which is this blue structure, which is called the dorsal nucleus of vagus. All right, holy crap, we got all that done, thank goodness. All right, now we're going to go ahead and start flying through this. Okay, so we have the GVE fibers moving through the internal acoustic meatus. Okay, so now let's go into the next one. What about these GSA fibers? Where are they coming from? Okay, they're touch pain temperature fibers. They're going to be primarily supplying the tympanic cavity and the tympanic membrane and a little bit of the external acoustic meatus and even a little bit of skin around the ear. So if you look here for a second, what you're looking at, this is actually going to be kind of a look at the tympanic cavity. If you look at the tympanic cavity, this would actually be the medial wall. So this is your medial wall. This is the anterior wall. This is the posterior wall. And then I've taken out the actual lateral wall, so you can't see the lateral wall. Okay? So we have medial wall, anterior wall, and posterior wall. Okay? So let's have that right there. Now, what happens is, you're going to have these GSA fibers. We have them in blue here, right? These GSA fibers are going to provide touch pain and temperature fibers to the tympanic cavity. So let's say this whole little cavity in here is the tympanic cavity, right? It's going to give fibers there. Where else is it going to give fibers to? Okay, we also said it's going to give a little bit to, let's come down here for a second so we can see another view here. If we look here, this is just looking in, taking in, you can only see a little bit of the posterior wall, you can only see a little bit of the anterior wall, right? And this is the floor of it. Well, if you look here, this is going to be the actual lateral wall. So this part here is the lateral wall. So this is the lateral wall of the tympanic cavity. Because if you can imagine for a second here, if I were to just kind of do real quick here, little quick thing here, this would be, this side right here would be the posterior wall. This would be the medial wall, and this would be the anterior wall of the tympanic cavity, right? Okay, so that's the lateral wall. So we know that these GSA fibers are supplying the tympanic cavity, and we also know that they're supplying the tympanic membrane. Okay, so we said it's supplying the tympanic cavity, the tympanic membrane. All right, what else is it supplying? It's also supplying the external acoustic meatus. So now if you look at this view, we're looking at this from the anterior side. So right here is the tympanic cavity. So this is where some of the actual GSA fibers are going to go. This right here is the actual tympanic membrane. If that's the case, then it's also going to give fibers to the tympanic membrane. And it's also going to give fibers that are going to go and supply the external acoustic meatus. And it might have a little bit of fibers that come out here and supply a little bit of skin on the back of the ear. Okay? All right, so that's the auricular branch. So this fibers right here, these are actually called your auricular branches. And if we follow these auricular branches upwards, again, what are these fibers? GSA fibers. This auricular branch is going to have something really, really interesting. It's going to have a ganglia. You know, ganglia, what is a ganglia? A ganglia is just a group of cell bodies located within the peripheral nervous system. It has a special ganglia located out here. You know what this ganglia is called? This ganglia is called the geniculate ganglion. What happens is these GSA fibers, which are coming from what? It's going to come from the tympanic membrane, it's going to come from the tympanic cavity, the external acoustic meatus out here, and a little bit of skin around the ear. It's going to send its actual central processes into the central nervous system. And where did we say that it was going to send it? It's going to go to the spinal nucleus of the trigeminal system because it's carrying touch, pain, temperature fibers. So it'll go through the internal acoustic meatus and then give off these fibers here to the trigeminal system. Okay, specifically the spinal nucleus of the trigeminal system. Cool deal. So we got GSA fibers, and again, what are these GSA fibers supplying? They're supplying the tympanic cavity. They're supplying, I'm going to put tympanic membrane, and it's supplying the external acoustic meatus, and even a little bit of skin right behind the ear. And that's called the auricular branch. So this whole branch here is called the auricular branch. Sweet deal. All right, now let's go to the next one. Let's do the next sensory ones because we're going to do the motors and we're going to follow the motors afterwards. Okay, so let's follow the next one. Let's do the GVA since it's a pretty quick one. We're going to do the GVA fibers. So the GVA fibers are basically going to be general visceral afferents. They're picking up a little bit of touch, pain, and temperature and visceral sensations from specifically the soft palate. So let's come over here for a second. So if you guys remember, I'm going to do this one in this orange color here. Actually, I'll do it in pink. So here, we're going to have here, remember this is your hard palate. Let's say I separate it right here. This would be hard palate. This would be soft. And this whole structure here would be the uvula, right? Which is basically an extension of that soft palate there. The soft palate is going to have these GVA fibers. And these GVA fibers are going to be picking up visceral sensations here, right? And carrying this where? It's going to be carrying these visceral sensations over to these ganglia. What is this ganglia called? The geniculate ganglion. Where's it going to go from the geniculate ganglion? It's going to send its actual what? Its central processes inwards. Where are these going to go? We said that the visceral sensations can go to two places. One is it could go a little bit to the nucleus attractus solitarius, or it could go to the dorsal nucleus vagus. All right? And again, these are your GVA fibers. Okay? All right, sweet. Now let's do the next one. Let's do another sensory one. Let's do the SVA fibers, the special visceral afferent fibers. And the special visceral afferent fibers are picking up taste from where? Of the anterior 2/3 of the tongue. And we're going to make this one that doo-doo brown color here. Okay, so if you guys remember from the gustation video, we had these papilla, right? Remember these fungiform papilla right here? We had these fungiform papilla. They were the main papilla, the like anterior 2/3, right? Well, remember due to the different types of taste, right? Salty, sour, sweet, umami, bitter. Those substances can be picked up by these actual taste buds in this area, right? And then what happens? It's going to get picked up by these SVA fibers, which are carried by what nerve? The facial nerve. Now here's something really interesting that I want to talk about here. What nerve, this actual nerve here, these carrying these SVA fibers, they're actually moving with two other structures that we should talk about real quickly. What are these other structures that it's moving with? You know, there's actually something called the lingual nerve. Remember we had here, if you guys remember, we had the trigeminal ganglion right here. It was right here in that petrous part of the temporal bone, right? And remember it's giving off three branches. One was a V1 branch, which is the ophthalmic division. One was the mandibular division, the maxillary division. And the other one was the mandibular division, V3. If you remember, this guy gave off a couple different branches. One of the branches, though, was actually going to be the lingual nerve. And the lingual nerve, if you guys remember, runs with these actual taste fibers. And then what does it do? It gives touch, pain, temperature fibers to the anterior 2/3 of the tongue. But remember, this was from the trigeminal nerve. So what is this nerve here called? This is called the lingual nerve. This is called the lingual nerve. Now, before we follow this back, I'm going to follow one more guy here. Okay, we're going to talk about a little bit more of this in just a second, but for right now, let's take these green fibers, these GVE fibers, these general visceral efferent fibers, and we're going to follow them for a second here, and they're going to make a turn, and they're going to go down this structure here. Okay, so it's going to come around this turn here, and it's going to go down this little canal. You know, this is called the facial canal. It's like a little bony canal within the actual middle ear cavity. And then what happens is, it'll come through this facial canal, and it'll jump out of the facial canal. So it'll jump out. Then when it jumps out of the facial canal, it'll go through a tiny hole in the posterior wall called the posterior canaliculus, right? So it'll come through this little like canal right there, this tiny little canaliculus, and it'll move anteriorly. So it'll move through the cavity. As it moves through the cavity, it'll come out the anterior wall. So it's going to come out of the anterior wall. Then what happens is, it's going to go through a hole. It actually would go through a hole up here, but I'm going to show it for right now. I'm going to show it right here. There is another hole here, and it's between the actual the tympani, the actual temporal bone, and another part here. You're actually going to have this thing called the petrotympanic fissure. So you have this thing called a petrotympanic fissure. And what happens is it's a tiny little hole that this actual GVE fibers run through. Not only the GVE fibers run through this, but guess what else runs with it? The SVA fibers. Because guess where the SVA fibers are going to go? We'll talk about that in just a second. It's going to run also with this actual fiber here, these GVE fibers, through this petrotympanic fissure. Okay, so now let's follow this GVE fiber here. These GVE fibers, or these secretomotor fibers, are going to move with the lingual nerve. So what's basically happening here? these GVE fibers and the SVA fibers are going to hop on with the lingual nerve. So they're basically running all together. So if you think about it, all of these guys are running together like this. So it's pretty cool. So when you look at these guys are all running together. What's running together? So in the lingual nerve, you're going to be picking up SVA fibers and you're going to be having these secretomotor fibers. Okay. Now, where does these secretomotor fibers go to? The secretomotor fibers are going to actually go to a specific structure over here. When the secretomotor fibers or these GVE fibers come here, they're running with the lingual nerve and they're running with these SVA fibers. They come out. All right, they're like, I've had enough of this. And they go to a ganglia. Another ganglia. What is the definition of a ganglia? It's a group of cell bodies within the peripheral nervous system. These ganglia come out and serve two glands, right? So these actual postganglionic motor neurons come out and supply two different glands. Okay. One gland is actually going to be called the submandibular salivary gland. So there's the submandibular salivary gland. It basically produces some saliva that can actually go into the oral cavity. And then there's another gland here. Another gland called the sublingual salivary gland. So two glands here. One is the submandibular salivary gland. And this one over here is going to be the sublingual salivary gland. Now the question is, what is this actual ganglia right here? What is this ganglia called? This ganglia, where the group of cell bodies of the postganglionic parasympathetic motor neurons are, this is called the submandibular ganglion. All right, so the submandibular ganglion. Okay, so now let's go ahead and make sense of all this. Let's follow the trigeminal, let's follow each one piece by piece so that we can make sense of this and we're not confusing this, all right? So again, trigeminal nerve, right? You have the trigeminal ganglia. It gives off a V3 division, which is the mandibular division, runs through this hole, which is called the foramen ovale. Out of that can give off branches. One of the branches is the lingual nerve. The lingual nerve is going to be taking touch pain temperature fibers to the anterior 2/3 of the tongue. What's running with it? Remember, you're going to have SVA fibers of the facial nerve, which is going to be picking up taste from the anterior 2/3 of the tongue. These SVA fibers are going to also be moving with the lingual nerve. What's also going to be moving with the lingual nerve? Well, now we got to come back up here to the actual brainstem. Well, what's coming with it? If you remember, we had the superior salivatory nucleus. Some of these fibers, right, will actually go down through this bony canal, this facial canal. It'll come out of the facial canal and go through what's called the posterior canaliculus, the anterior canaliculus, and then go through the petrotympanic fissure, which is also going to be moving with the SVA fibers. And then it's going to hop onto the lingual nerve. When it moves together, they'll all be moving together within the lingual nerve, but as these GVE fibers get closer and closer and closer to the tongue and they give off they come out of that actual lingual nerve and they go to the submandibular ganglion, where they synapse on the cell bodies of the postganglionic parasympathetic motor neurons, which go to the sublingual salivary gland and the submandibular salivary gland, which are then going to produce saliva. All right. Now that we got that, let's follow these guys back a little bit more, specifically these SVA fibers. So these SVA fibers, some of them can actually go up through a different route. We're not going to talk about that. And most of them will actually go this way here too. So they're going to be coming with this actual GVE fibers, and they'll also go through the posterior canaliculus, and they'll actually come through the anterior canaliculus, and they'll actually go back into this bony canal, this facial bony canal, and they'll come out, and then what? They'll move through the internal acoustic meatus, and where are they going to go? They should go to the nucleus attractus solitarius, right? So they should go to the nucleus attractus solitarius. Why? Because we said nucleus attractus solitarius receives SVA fibers and GVA fibers. The SVA fibers are the special visceral afferents, which are the taste of the anterior 2/3 of the tongue. Sweet deal. So we got that. Why did I want to mention these together? Because when you look in the ear and you look at the tympanic cavity, you're going to see a cord that's moving from the posterior wall to the anterior wall. They gave it a special name. They always got to give it names, right? What is the name of this cord? Well, it's a cord, and it's in the tympanic cavity. So they decided to call it, let's just call it chorda tympani. So what is this structure here called? It's called chorda tympani. And what is the chorda tympani? It's basically going to be the SVA fibers of the facial nerve and the GVE fibers of the facial nerve. That's it. Okay, let's keep going. So what have we done so far? We've covered these guys. We did the SVA fibers, we did the GVA fibers, we did the GSA fibers. Let's do the SVE fibers because they're pretty easy. Okay, let's do the SVE fibers. So now we're going to do special visceral efferent fibers. Now again, it'll come out through the internal acoustic meatus. Then, these actual red fibers here, as they go through the internal acoustic meatus, they come out here, and they'll go into this, again, this facial canal. They'll go through the facial canal, and then what happens? They don't come out. They continue to keep going downwards, down the actual posterior wall of the tympanic cavity. So now it continues to go down. I'm showing these dotted lines to represent that it's in the posterior wall. So it's coming down the posterior wall, and then it comes out through a special little hole. And this hole is in between the styloid process and the mastoid process. So they call this hole that it exits out of called the stylomastoid foramen. So what is this hole called? Stylomastoid foramen. Sweet. So that's that hole there. Now, I wouldn't be doing you guys any type of justice if I didn't mention something else it does. As it's coming down, there's a special structure. But the only way we can really see this is if I get rid of these actual walls, or I kind of push these walls outwards. So now we're going to take a look here down in this part here. So look at this for a second. This is a kind of a nicer view to see how this bony canal is working. So again, this is what wall is this? This is the medial. This is the anterior. And this is the posterior wall. And I've gotten rid of, a couple other pieces here. But we're just kind of looking at it like in this now, right? Now, what happens is these actual motor fibers run through the facial canal down this wall. But as they're going down to come out of through that stylomastoid foramen, there's a little area right here. You know there's little bones inside of your middle ear called the ossicles? So what are these little ossicles called? You know you have malleus and incus and stapes. Stapes is really important. Okay, because stapes is tapping on a specific, you see that window right there? This is called the oval window. And then what do you think this one is? It's round. So it's called the round window. What happens is stapes is tapping on the oval window. But you know there's a muscle that's connected to it right here? It's kind of like hooking it like this. Look at this muscle. You know what that muscle is called right there? That muscle is called the stapedius muscle. So it's called stapedius. What happens is the facial nerve gives off a branch that goes and supplies the stapedius muscle. If it innervates the stapedius muscle will contract and prevent stapes from continuously tapping on the oval window. So what is the stapes doing? The stapes is tapping on the oval window, but the facial nerve is innervating the stapedius, and when it innervates the stapedius, it keeps preventing the stapes from tapping on the oval window excessively, so that there's not excessive sensitivity to sound. That's why it's extremely dangerous whenever someone has Bell's palsy. They can actually have hyperacusis, where there's very sensitiveness to sound because the stapedius is no longer going to be innervated by the facial nerve if there's some type of damage. And then the oval window is just going to continue to get tapped on by stapes, and they're very sensitive to sound. They actually hold their phone out all the way out here because it hurts so much when someone's actually talking very closely into their ear. Okay, so that's that one. Now, it comes out through the stylomastoid foramen. And when it comes out through the stylomastoid foramen, it gives a lot of branches here. What are these branches? We're going to go over each one of these branches. Okay. So now, one of the branches here is called the temporal branch. So you're going to have a temporal branch, okay? You'll also have a zygomatic branch. So a zygomatic branch. You'll also have a buccal branch. You'll have a marginal mandibular branch. And you also have a cervical branch. So what are the 5 branches? You'll have a temporal branch, a zygomatic branch, a buccal branch, a marginal mandibular branch, and a cervical branch. And it's not too hard to think about it, because when we look at the actual face now, because we're going to go over to this guy over there in the top right corner, we're going to see what each one of these branches are doing. And it's going to make a little bit more sense. So just for the sake of it, so I'm not having too much of one color in this area, I'm going to make that motor fiber blue just for a second, okay? So we're not confusing it here. So one is the temporal branch. I'm going to put T here for the temporal branch. The temporal branch is going to supply what? Okay, it can supply a bunch of different structures. We're not going to go over into every single one of them, but some of the big ones is it's going to supply this muscle right here. You know this muscle right here? We'll denote this muscle 1. This muscle is called the occipitofrontalis. Or you can just call it the frontalis if you want. It's the frontal belly, right? So it's called the frontalis. Okay? It's also going to innervate another structure right here, right above the actual, right around this actual eyebrow region right here. This is going to be another branch. And this is going to give fibers to this muscle here. This is muscle number 2. This muscle is called the corrugator supercilii muscle. Supercilii muscle, right? What else can it supply? It can also give off another branch to a very important muscle right here, which is going to be the third muscle here, this one that's wrapping around the actual eye. It's like a sphincter. This is 3. This is called the orbicularis oculi. Right, so it gives off many branches. So this is the temporal branch. So the temporal branch is actually supplying mainly, in this case, 3 main muscles. What is it? It's going to be supplying the occipitofrontalis, it's going to be supplying the corrugator supercilii, and the orbicularis oculi. All right, now let's do the actual zygomatic branch. So the zygomatic branch is actually going to have supply. It can give a little bit of supply to the orbicularis oculi. It can even give supply. These ones are pretty easy because it actually has its name in it. It also can give branches to these 2 muscles. Okay, one is called the zygomaticus minor. The other one here is called the zygomaticus major. And it's even going to give another branch to this muscle right over here. And this one is actually going to be called the, you specifically call this one the levator labii superioris. And then there's another one over here called the levator aliqui nasi. I'm not even going to attempt to spell that. Okay, so it's called the levator aliqui nasi, right? So that's going to be the zygomatic branch. Okay, so again, what do we have for the temporal? Temporal is occipitofrontalis, corrugator supercilii, orbicularis oculi. Then zygomatic is going to supply the orbicularis oculi. It's going to supply the levator aliqui nasi, the levator labii superioris, the zygomaticus minor, and the zygomaticus major, right? Then we're going to have the buccal branch, right? So we'll have another branch here, which is going to be the buccal branch. And the buccal branch is pretty easy. It supplies a very, very strong muscle in there, which is in the cheek, called the buccinator. So it is going to supply a muscle here called the buccinator. And it's even going to give a branch over here to another muscle. This is called the risorius. Okay, so this is called the risorius. So it's even going to supply the risorius. And what else are we going to have here? So we'll have the buccinator, we'll have the risorius. What else would you have in this area? You can even have the orbicularis oris. So it can even give branches to the orbicularis. What is this muscle right here called? Orbicularis oris. Ooh, this guy does a lot, right? And then what else do we have? We have the marginal mandibular. And the marginal mandibular branch is going to give off what? It's going to supply the triangularis. It's going to supply the depressor labii inferioris. It's going to supply the mentalis. Right? So what does it supply here? It can supply the mentalis. It's going to supply the triangularis. Or if you want, you also can call it the depressor anguli oris. And then it's also going to supply another muscle right here, and this muscle is going to be specifically called the depressor labii inferioris. Wow, this is a lot, man, huh? And then it's also going to give other supplies, one more other supply here. And it's also going to specifically give supply to the platysma. And this platysma is actually from the cervical branch. So from the cervical branch, it's going to supply the platysma. Now, when it comes out, the stylomastoid foramen, there is no specific name for this branch. It just comes out and supplies, not only does it supply the stapedius, but it comes out. There is no specific name for this branch. It is not the temporal, it is not the zygomatic, it is not of the buccal, it is not of the marginal mandibular, and it is not of the cervical. This is just its own branch, and it comes out of that stylomastoid foramen. When it comes out of the stylomastoid foramen, it gives supply to these two muscles right here. One muscle is called the digastric posterior belly. The other muscle here is going to be the stylohyoid. Okay? Okay, so let's review that real quick. Right? So the temporal branch. What is the temporal branch supplying? And again, this is the temporal branch. The temporal branch is supplying the occipitofrontalis. It's supplying the corrugator supercilii. It's supplying the orbicularis oculi. The zygomatic branch is supplying the what? The zygomatic is also giving branches to the orbicularis oculi. It's giving it to the levator labii superioris. It's giving it to the zygomaticus major, the zygomaticus minor. The buccal nerve is going to be supplying the buccinator. It's going to be supplying the orbicularis oris and the risorius muscle. The marginal mandibular will be supplying the triangularis, or you can also call it the depressor anguli oris, right? And it's also going to be supplying the depressor labii inferioris and the mentalis. And the cervical is going to be supplying the platysma. And then remember, this is not a specific branch, it's just giving off fibers. When the facial nerve comes out of the stylomastoid foramen, it goes and supplies the stylohyoid and the digastric posterior belly. Okay? So it supplies a lot of these muscles of facial expression. And just for time's sake, I don't want to go through every single action of these muscles. If you guys have some time, we made a video on the anatomy of the muscles of facial expression of the head and neck. So if you guys want to go ahead and watch a video and you can see the anatomy models of all of these muscles, and we mention all of their functions, okay? But we're not going to do that right now, okay? So again, that covers all the actual branches. So as we talked about the special visceral efferent fibers that are supplying the second pharyngeal arch, which are the muscles of facial expression, the stylohyoid, the digastric posterior belly, and do not forget, the stapedius, okay? All right, now we go into the more complicated one of these, okay? So we did that. Oh, real quickly, I forgot to mention this one here too. Remember those SVA fibers? They don't just go straight in, right? They have to synapse on a ganglia. So these SVA fibers, these brown fibers, remember they were coming up as part of the chorda tympani, and they were coming up through the bony canal. They were coming through this part right here. They also give off they also have a pseudo-unipolar cell body out here, a ganglia, which is going to be a part of the geniculate ganglion. So the geniculate ganglion is going to have ganglion cell bodies for SVA fibers, GSA fibers, and GVA fibers. Okay, so don't forget that there. Okay, now we go into this last part here. Now, whenever these fibers are moving into the facial canal, a lot of them are moving right through there, right? What happens is some of these green fibers here, now some of them will go down into the facial canal, but some of them will branch off. They decide to take their own course. And they come up, 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 and they move through a little hole here in the skull. You know, they'll move up through the middle cranial fossa through a little hiatus. There's actually a tiny little hiatus here. It's called the hiatus of the greater petrosal nerve. So what happens is it'll come off here, it'll move through this tiny hiatus, and it'll move through the middle cranial fossa. And what is this nerve here called? This nerve is called the greater petrosal nerve. The greater petrosal nerve will continue to move forward and forward. So it moves through, what's this little thing here called? It's called the hiatus of greater petrosal nerve. Then it moves in the middle cranial fossa and comes out through another hole. This hole is a very, very interesting hole, okay? This hole is called the foramen lasserum. So this hole right here is called the foramen lasserum. What else actually moves through this hole here? If we know our anatomy here, we should also know that what other structure is coming up through here? The internal carotid artery. So you're also going to have the internal carotid artery moving up through the actual foramen lasserum into the cavernous sinus, right? So you're also going to have the internal carotid artery there. But the greater petrosal nerve will move through the foramen lasserum. When it comes out of the foramen lasserum, it goes into this weird little canal here. This weird little canal. And this weird little canal is called the pterygoid canal. So what is this little canal here called? It's called the pterygoid canal. it'll move through this pterygoid canal, this little bony canal, and go into this little fossa here. What is this fossa here called? It's called the pterygopalatine fossa. So it's called the pterygopalatine fossa. Why am I mentioning this? Because remember they had a ganglion for those actual secretomotor fibers for the salivation? Well, these have to have ganglia. They have to have cell bodies of the postganglionic parasympathetic motor neurons. So guess what? These parasympathetic fibers, they have a ganglia in this area. What is this ganglion here called? It's called the pterygopalatine ganglia, which is in the pterygopalatine fossa. So what is this called? This is called the pterygopalatine ganglion, right? And then what happens? Before we do that, we have to know something else. You know, there's another special little nerve here. Let me do this one in orange. Okay, you know the internal carotid artery? We have it right here. If I were to actually follow it up here, I kind of drew a little bit of it down here to kind of show how it's actually happening. But we're not going to go down. I'm going to bring this a little bit like this here. Okay. So the internal carotid artery, we already know that it actually is going to move up through the foramen lacerum, but something really cool happens. If you guys know a little bit about your autonomic nervous system anatomy, you know there's what's called a superior cervical ganglion, which is a part of your sympathetic nervous system. This will come from your spinal cord. I'm just going to put SC for spinal cord. There are going to be these axons that will come out to these things called the superior cervical ganglion. Then these postganglionic fibers from that superior cervical ganglion will come out here, and it'll form like this little plexus, a weird little plexus wrapping around the internal carotid artery. There's going to be this plexus wrapping around the internal carotid artery. It's a sympathetic plexus. As it's going that way, it gives off a sympathetic plexus that moves with the parasympathetic nerve in through the pterygoid canal. And then it moves into the actual pterygopalatine fossa. What is that nerve called? They call this the deep petrosal nerve, right? And it'll run through the pterygoid canal with the actual, what is this? The greater petrosal nerve into the pterygopalatine fossa. Now, because, probably some doctor, he was like, yeah, I'm going to name this whole thing the Vidian nerve. So that's what they did. They call this whole nerve here that's running through the pterygoid canal, they either call it the nerve of the pterygoid canal or they call it the Vidian nerve. Doctors always got to make things more complicated for us, right? So it's called the Vidian nerve, or if you prefer, you can call it the nerve of the pterygoid canal, right? So again, just to make sure that we're clear here, this is the internal carotid artery. I was going to have it, actually, here, let's come down here for a second just so we can see it connected here. So right here, this is going to be the common carotid artery. This right here is the common carotid. So I was going to show here the common carotid artery. It actually comes up, and here's this kind of like little sinus part here. It actually branches out into two parts. This is the internal carotid artery, and this is the external carotid artery. Okay, so this is the one that I was saying here. And if you remember, we said here that we could have like a little cross section of the spinal cord here. You'll have here a special structure here. You'll have these cell bodies in the lateral great horn. They'll come out and upwards to what's called a superior cervical ganglion. And then from there, they'll come out and wrap around the internal carotid artery. So let's say that I show this internal carotid artery just continuing up and feeding into that one. Let's say I feed this up like this. Okay? And then what's actually wrapping around it? It's this sympathetic plexus. So the sympathetic plexus is actually coming and wrapping around this sucker here and then moving upwards. But as it's moving upwards, what happens? It gives off a little branch called the deep petrosal nerve that runs with the actual, what is this green nerve here called? Son of a gun. This nerve is called the greater petrosal nerve. It runs through the pterygoid canal as the Vidian nerve, or the nerve of the actual pterygoid canal, into the pterygopalatine fossa. Now, what happens is, let's follow this greater petrosal nerve. The greater petrosal nerve will actually come out of the pterygopalatine fossa, and this is the postganglionic fibers, right? Postganglionic fibers. It'll run up through the inferior orbital fissure. There's other nerves that are also running through this area too, which are part of the maxillary nerve. Remember, you have the zygomatic nerve. Then you have the infra-orbital nerve. And remember, the zygomatic nerve gives off two branches. One is the zygomatical facial and the zygomatical temporal. This greater petrosal nerve is going to be moving with these guys, but then what happens if it gives off this branch here, and this branch is going to be coming over here to the lacrimal gland. So it's going to come to this gland here called the lacrimal gland, and it's going to trigger the lacrimal gland to produce lacrimal fluid, which is just basically your tears, right? So it's crying. Okay, so it's producing this lacrimal fluid, and it's important because lacrimal fluid has a lot of different antibacterial functions. Okay, and then if you really want, this actually can follow with it, and it can also go to different places also. Okay, we're not going to talk about that. It can go into a lot of different areas that we're not going to talk about right now. Okay, so again, that's that part there. Now, from that, it also can go to the lacrimal gland, but guess where else it can go? It can give off some fibers that move downwards. Guess what? There's little nasal glands here. Nasal glands that are part of your nasal mucosa. It can also come out to these nasal glands. So it can come out to the nasal glands and cause these nasal glands to produce certain types of nasal fluid to help to humidify the air, to warm the air, to moisten the air. So it helps the nasal glands to produce nasal mucus, right? So it helps to produce a nasal glandular gland secretions. All right, nice. So we know that it's supplying the actual lacrimal glands, the nasal glands, and it even can give a little bit of nerve supply here to the palate. The palate also has some small palatine glands here, and it can innervate the palatine glands here to produce certain types of palatine secretions. Okay? Sweet. So again, with that guy, that little sucker there, nerve branches off here, comes up through the hiatus of the greater petrosal nerve, runs within the middle cranial fossa, goes through the foramen lassurum, which is also moving upwards as the internal carotid artery. As it goes downwards as the greater petrosal nerve, it goes into the pterygoid canal. What else comes with it? As the internal carotid artery is coming up, the sympathetic plexes, which are coming from the superior cervical ganglion, are going to move with it. That is the deep petrosal nerve. If they run together, they're pterygoid canal. They're called the Vidian nerve, or the nerve of the pterygoid canal. They go into the pterygopalatine fossa. The parasympathetic, or the greater petrosal nerve, will synapse on the cell bodies of the postganglionic motor neurons. That'll come out and go through the inferior orbital fissure, which will move along with the zygomatic nerve, which branches into zygomatical temporal, zygomatical facial, and it'll also move through with the infraorbital nerve. It'll come off of these guys and give a communicating branch that will move to the lacrimal gland. It also gives movements over here that'll go to the nasal gland and the palatine gland secretions. Okay, now that covers all of these fibers. Amazing. Okay. Now that we've done that, we've seen the course of the nerve, the origin of the nerve, the structures that are supplied. What we're going to finish off with is clinical correlation. Okay, so a lot of different things can happen with the actual facial nerve. There's a lot of things that can happen. You could get an acoustic neuroma that could actually occur here. Would actually not only, that's a good point that I want to bring up real quick. You know what other nerve runs through here? The vestibulocochlear nerve, cranial nerve 8. So cranial nerve 8 also runs through this area. So if there is some type of tumor here that actually is going to be developing, it can compress not only the facial nerve, but also the vestibulocochlear nerve. So this could produce a lot of problems. Now, what is the most common thing that's affecting the facial nerve? This most common thing that's affecting the facial nerve, let's talk about the clinical correlations over here, is actually going to be that of what's called Bell's palsy. So what is Bell's palsy? Well, Bell's palsy is usually due to some type of herpes simplex 1 virus. So if someone has, most people, like 97% of the population have actually been exposed to this herpes simplex 1, but it's usually in the latent stage, right? So what happens is, if this herpes simplex 1, which is in like the latent stage, becomes reactivated for whatever reason, and it actually gets reactivated and goes into a specific lytic cycle, what happens is your immune system becomes activated. When your immune system becomes activated, the immune system starts attacking the facial nerve. And whenever the facial nerve is attacked, it actually can develop a lot of edema. And then where is this most commonly going to be affected? Okay, well, let's come back over here to this little area over here for a second. So if you remember here, we had the internal acoustic meatus, which led into this little bony canal. If nerve edema develops within this bony canal here, it starts to swell. As it starts to swell, there's not much movement there. These bones are not going to expand for that. So what's going to happen? It's going to be compressed by the bony walls of this facial canal. As it starts being compressed, the facial nerve becomes compressed. What could happen from this? So many things. They would lose, let's follow each fiber and see what it would affect. if these tan fibers are affected, you would lose taste. So your SVE fibers would actually be affected, right? So you'd lose, taste within the anterior 2/3 of the tongue. If these blue fibers are affected, then what? You'll lose touch, pain, temperature, sensations, right? Within the, specifically within the tympanic cavity, within the tympanic membrane, and even around the external acoustic meatus, and even the patch of skin around the ear. But particularly, it can actually develop into a neuropathic pain. So not only would you lose the touch, pain, temperature, but it actually can lead to what's called a neuralgia, or a neuropathic pain that can develop in that area. All right, what about these pink fibers? You might lose visceral sensations from the actual soft palate. What about the red fibers? This is probably the most affected. If the red fibers are affected, it can't innervate. What was that muscle that I said was super, super important? What was that muscle here? It was called the stapedius. Remember what the facial nerve did to the stapedius? It caused the stapedius to contract and prevent it from tapping on that oval window so hard. If the stapedius is actually not going to get innervation, it can produce something called hyperacusis, which is very, very sensitiveness to sound. Okay? So again, like I said, they might have to hold their phone all the way out here, because if they talk to the phone on someone, it can hurt really, really bad. Okay? Okay, that's that thing. Okay, what else could be affected? Well, we said, look at all these motor branches. They go like everywhere. You give a temporal branch, a zygomatic branch, a buccal branch, a marginal mandibular, a cervical. What would happen to this person? Oh my goodness. You know, if you look at it, they wouldn't be able to control the wrinkles of their forehead. Look here, if the actual orbicularis oculi is super, super important, which controls basically the blinking or the closing of the eye. Also, all these muscles, the zygomaticus major, the zygomaticus minor, wouldn't be able to function. So you know what, actually something weird really happens? Let's say that the right facial nerve is affected, so then the zygomaticus major and the minor can't contract, they can't smile, right? So they won't be able to bring this side of the face up. When this side smiles, it pulls. So the zygomaticus major and the minor compensates, and it actually pulls the cheek upwards. So then they look like this. They look all fricked up, right? So it's going to have the zygomaticus major and the minor pulling this side up. All these other things could happen too. So, and then on top of that, they would actually be drooling a lot. They wouldn't be able to keep their mouth closed too. So the orbicularis oris would be affected. So they have a lot of things leaking from their mouth. When they sleep, they actually might even have to put tape on their eyes, because their eye would just stay open the whole time, because they can't actually control the blinking process. Right? So there's a lot of things that could happen because of this. It's a very, very, very sad and unfortunate thing. And this is called Bell's palsy, right? So it could affect the muscles of facial expression. It could affect the taste fibers. It could cause neuropathic pain within the ear, the external acoustic meatus, tympanic membrane, and the patch of skin around the ear. And what else we said? It also could affect the actual salivation process, because it gives fibers that go to the submandibular ganglion. So they won't be able to produce saliva. And if they can't produce saliva, what can happen? You know, saliva is very important for basically keeping the mouth clean. So if that's the case, then they might develop halitosis. They might develop an increased sensitive incidence of maybe dental caries or cavities or gingivitis, right? But again, they'll have halitosis, some stank breath, right? So that'd be rough. And if you also injure the greater petrosal nerve, what happens to lacrimation? So they might not be able to produce tears effectively too. So many different things, unfortunately, can happen to this person. But you know, Bell's palsy is not the only common thing that affects the facial nerve. There's many other things that can also cause similar effects besides Bell's palsy. Other things could be like Lyme's disease. So Lyme's disease is actually able to cause that facial paralysis, but usually it presents with other things like a rash and dysarthria, and maybe some type of radiculitis and encephalopathy and stuff like that. Could be due to sarcoidosis. Sarcoidosis is basically just kind of an inflammatory reaction where you produce these things called granulomas, basically accumulations of inflammatory cells that can occur within like the eyes, the skin, the lymph nodes, the lungs, different tissues in the body, and even in the nervous system. All right. And you could even have this due to herpes zoster. So herpes zoster could also cause this effect too, which actually could produce a very weird situation where they develop vesicular rashes in the ear, and they can develop what's called Ramsay-Hunt syndrome type 2. Okay, so what other causes could be, you know, leading to this facial paralysis? There could be other causes besides herpes zoster. It could be like otitis media, which is basically a middle ear infection. But this is extremely dangerous because if not treated very, very quickly, you know, or within an appropriate amount of time, it can lead to brain abscesses and meningitis and Other things could be like Guillain-Barré syndrome. I'm not going to spell that. I'll put here, I'll do the Barré syndrome. Okay? But some type of demyelinated condition of the peripheral axons. This could also affect the facial nerve. Okay? But in general, it could be due to Bell's palsy, which again could be due to the herpes simplex 1. All right, so I'm going to kind of separate these here. Herpes simplex 1 could actually reactivate the herpes simplex 1 virus. The immune system could actually attack the facial nerve, primarily within the bony canal, cause the nerve edema, and compress those and cause a lot of different types of effects, right? So try to give them corticosteroids. All right, Ninja, so in this video we covered a lot about the facial nerve. We went over a lot of depth on all the different origin of the nerve. We talked about the course of the nerve, we talked about the structures that it's supplying, and we talked a lot about the clinical correlation with it. I hope all of this made sense. I hope you guys really did enjoy it. If you guys stuck in with us the whole time, I really appreciate it. If you guys would please hit that like button, comment down in the comment section, and please subscribe. As always, Ninja Nerds, until next time.